Good afternoon, everyone. Welcome to your sixth and final CLHO legislative training. Today we are going to focus on an overview of the Oregon Revised Statutes related to public health. And Danna Drum from OHA is really going to do the presentation. I'm just here as a facilitator. So thank you for being here. Given that it is over the lunch hour, please feel free to take yourself off camera and eat your lunch. We are recording this webinar so that other folks can access it later. So if you don't want to be on camera eating your lunch, feel free to take yourself off camera, and we'll have time for questions at the end, hopefully. So if you want to come back on camera to ask questions, that's totally fine. And with that, I believe I will turn it over to Danna Drum.
All right, let me share my screen. All right, are you seeing slides?
Yes, I am.
All right. So, hello, everybody. I think I know everybody on here, but in case not, I'm Danna Drum. I'm the local and tribal public health manager in the Oregon Health Authority Public Health Division. And I spend a fair amount of my life with these statutes, often in partnership with the Oregon Department of Justice. So today, I thought I would just do kind of a general overview of the public health Oregon Revised Statute structure to kind of help you, especially those of you who may be less familiar with them, to sort of just know where to go to find things. Same with the Public Health Oregon Administrative Rules. We'll talk a little bit about the Public Health Modernization related statutes, some other key public health statutes, and I've tried to do some of that in a sort of myths versus facts kind of scenario, just with some of the things we get, our team, will often kind of get questions about. The thing I would say to start with is that the Oregon Revised Statutes are, in general, and particularly public health is no different, they are a mixture of things, and they have been changed over time, and there have been times when certain parts get changed and others don't. And so, there may be some things that you go to the statutes for and you want a really clear, concise, consistent, systematic view of something, and you may or may not get it depending on what you're looking at. And that's part of the nature of kind of the sausage making of how laws are made. So, just sort of, I want to manage expectations around that. So the Oregon Revised Statutes, the Public Health Statutes, are in volume 12 of the Oregon Revised Statutes. So if you were to go to this website, this is where I usually go, what will come up is a list of all the volumes, and you'll see that volume 12 is public health. And I did something funky with my circle there. Anyway, you'll see here, there's a whole host of things that fall under the public health statutes. Chapter 431 is the primary one that has to do with sort of how public health is structured in Oregon. But after that, there's, a whole chapter on vital statistics. 433 has to do with disease, reportable diseases and disease control, like kind of different areas have their own sections within the statute, within the public health volume. So within ORS 431, you're going to find a lot of different things. You're going to find definitions about what is an LPHA, what is the governing body of an LPHA, who can be a local health officer. You've got, or a definition of a local public health officer. You've got OHAs. So this includes state and local. So you've got OHAs, public health functions, powers, and administrative duties. The state public health officer is called out as is the state public health director. The state public health advisory board membership and duties are included in this section. Foundational, or in this chapter, foundational capabilities and programs. So public health modernization, those foundational capabilities and programs, and I'll talk more about those in a few minutes, as well as sort of authorization for other public health programs. This is where the enforcement of local of public health laws is talked about, and the role of OHA and local public health administrators in that. The Conference of Local Health Officials is established in this section of the statute. And then talking about funding for local public health authorities, in particular as it relates to public health modernization, and then transfer of local public health authority, because transfer of local public health authority is directly linked to whether or not LPHAs are fully funded for public health modernization. And I'm happy to, I don't think I went into great detail in this, but I'm happy to come back to that at the end. But basically, we tell the legislature every biennium, and we did this last summer with a report, we put forward the number of $286 million. So basically what went in our pot for public health modernization. If the legislature funds that fully, then local public health authorities would no longer be able to transfer their local public health authority to the state. If we receive any amount less than that, then a governing body of a local public health authority could take action to transfer their local public health authority to the state. It outlined, this section of the statutes outlines the local public health authority powers and duties, as well as those of the administrator, the governing body duties. Talks about administrator salary, and I'll come back to that. Also the local public health officer role. There's information about how a health district could be formed. And then there's a section on local public health advisory boards, which are optional, by the way. So within the statutes, as I mentioned, you'll find the foundational capabilities outlined. It's at a very high level. It kind of just talks about what things fall under each of these categories. It's not extensive, and but I'll talk about where you'll find more about that. And then same with foundational programs. It talks about what specific, like what at a very high level falls under that. Then let me switch. Let me just check to see what the. Oh, and thank you. Whoever, it should have been Marie Bowman Davis who did those pretty graphics. I meant to give a shout out to Sarah Lochner, but whoever put them together, thank you very much. So Oregon administrative rules, and I think this is really important when you're wanting to understand local public health authority, you need to look at the statutes, but you also need to look at the administrative rules. And the Public Health Division's administrative rules, all administrative rules can be found at this website, but the chapter OAR chapter 333, you can see here are the place where all the Public Health Division's administrative rules are found in the OARs. There are a number of different rules, different programs you'll see here, but the ones that I spend a lot of time with are the Division 14 rules, because those are really about kind of, again, the state and local public health authority kind of infrastructure. So if you, and I would suggest if you've never looked at these, you should spend some time to review them. Within Division 14, so if you go to this website and then you can click down and then you'll see the different types of things that are in here. So, and this provides more, hopefully more clarity or direction around specific kinds of things that are kind of mentioned in the statute, but need to be further fleshed out. So for example, what a county has to do to, or what a board of governing body needs to do to request a transfer of local public health authority. If you're on our administrative rules list, you may have seen something that went out just a little bit later or a little bit earlier today around amending actually those rules to include some additional things due to some statutory changes that occurred in, I guess, 2019 that we just with COVID didn't get a chance to clean up. but talks about not those amendments or additions are around how a governing body of a local public health authority could request to get the local public health authority back after they've transferred it. So, because that was not outlined anywhere. So I'll start with myth or fact, foundational capabilities and programs. So let's just play along. Myth or fact, LPHAs are currently required to implement all foundational capabilities and programs. What do folks think? Myth or fact?
Myth.
Myth, yes. See if my fancy, oh, there it is, my animation work. That makes me happy. That's true. That is, you are correct. So the foundational capabilities and programs, as I mentioned, the ORS gives a high-level outline of what's included in each of them, but the rule provides more direction and kind of points towards that to the extent that funding is available, because we know that foundational capabilities and programs have not been fully funded through modernization through the legislature, that a local public health authority should implement to the extent that funding is available. And then the FAA in the rule that's referring to the Public Health Intergovernmental Agreement describes kind of more specifically what needs to be done. So that would be your program element 51, for example. And then it also indicates that the authority will consult with FAB as the Public Health Advisory Board as necessary on kind of the prioritization of those things given the amount of funding. So the next one, myth versus fact, CLHO minimum standards for local health departments. There are legally binding CLHO minimum standards for local health departments. Myth or fact? Just shout it out. It's hard to match that much. Anyone know?
Fact.
All right. It's a myth. So there used to be the Conference of Local Health Officials used to have a document that was called the minimum standards. And somehow it was treated as if it were statute or rule, but it wasn't, because they weren't in statute or rule. And therefore OHA could not enforce them. And there are also things that we would probably have never been able to get county governments and county councils to agree to in rule, I'll just say. So generally speaking, from OHA's perspective, the binding, kind of the legally binding standards are what are in Oregon Revised Statute, Oregon Revised Rules, and any contract or grant agreement between us and an LPHA. So those minimum standards are quite outdated, but occasionally I'll hear people talk about them. And yes, they were a document, but they were never statute or rule and not something that OHA can enforce on. Lindsay.
Correct me if I'm wrong. There are requirements related to CLHO in rule, right? Around like governance or being part of like the CLHO board and that sort of stuff.
So it's not in rule. In the statute, there's some basic language that basically says the Conference of Local Health Officials. I'll talk a little bit more about that and what their role is. And that every local health officer and every local public health administrator is a member of the conference by law.
Thanks. That's what I was thinking of.
Yeah, there is in the Oregon Administrative Rule some basically recommended sort of basic standards for a public health administrator, like, that they have some public health experience and they have a bachelor's degree. But it's not a requirement, it's not a must. And again, that's part of sort of the negotiation around rulemaking and rules advisory committees and county representatives not wanting Oregon Health Authority to have a say in their hiring practices, basically. So, myth or fact, OHA and CLHO concurrence. OHA and the Conference of Local Health Officials legally are required to reach concurrence on governmental public health system matters. Myth or fact?
Myth.
That's right. It is a myth. So, CLHO, this is basically what the statute says about CLHO's role. That CLHO may, and this is the conference, not the coalition, the conference may submit to OHA recommendations on kind of what is within the foundational capabilities and programs and other public health programs. The adoption and updating of the statewide public health modernization assessment, which we did with CLHO back in 2015, 2016. The development of and any modification to the statewide public health modernization plan, and then the adoption of rules kind of related to all of this. Now, there is some history to this that I think it's important for folks to know. Some legislative history. Prior to the 2015 legislative session, which is when there were significant changes to the public health statutes and how public health, that was when kind of the task force on the future of public health services, for 2014, they had put together recommendations around what became public health modernization. And Representative Greenlick, who was also on that task force and who was the author of the bill that established that task force and got public health modernization rolling, he then put forward a bill in the 2015 long session that took the recommendations from that task force and put them into statute. Now, the other thing to know is that in 2013, he had put forward a bill that I think split up the state into 8 regional public health districts. As you can imagine, that did not go over well. What came out of that was the task force to look at the future of public health services in Oregon. And then what came out of that was basically public health modernization and a lot of changes to the statute in 2015. Representative Greenlick did not feel that the requirement in statute that OHA and the Conference of Local Health Officials reach concurrence on most issues related to public health, he didn't feel like that was tenable. And he pulled that out of the statute. And it was replaced with this. Kind of the trade-off was that the coalition of local health officials, not the conference, the coalition of local health officials lobbied and worked with him to get representation on FAB. And so CLHO has now, I believe, or local public health, I should say, has 6 seats, I believe it is, on FAB now. There's a local public health officer, there's a CLHO, a Conference of Local Health Officials representative, and then I believe there are 4 other folks who are on as local public health administrators that come from a group of counties that are kind of grouped together by size. So what we have continued to do, though, is to continue to bring program elements and funding and those kinds of things to the Conference of Local Health Officials, because it's important that, I mean, if you're a significant part of the public health system and needing to work through those things together is really important. But that is something that's no longer in the statute. And that was very intentional on the part of Representative Greenlick. So myth versus fact. OHA does not delegate public health authority to LPHAs. Myth or fact?
Myth.
It's fact, mostly. Hold on, let me see what's in the chat.
But you do delegate our authority.
Hold on, I'm going to talk about it. It's fact mostly. So local public health authorities actually get their authority from the statute primarily. So if you look at ORS 431, it defines what a local public health authority can be. And for most things, delegation of authority from OHA to local public health is not necessary for the majority of the things you do. There are some exceptions, and an example of that is in the environmental health intergovernmental agreement. So the way that the statutes were written related to kind of the regulatory tourist pool, restaurant, and bed and breakfast facility kinds of programs, the way that's written, it indicates in the statute that OHA must delegate those authorities because they're actually established kind of as a state program. But in several of those, and it's not consistent across all of them, it actually kind of says that if the LPHA requests that OHA delegate the authority for those particular regulatory programs, that then, OHA has to do that. In one, it says that the LPHA requests the delegation of authority and OHA, agrees that the LPHA is able to, take on that responsibility, then OHA will delegate the authority. So that's the distinction, is that there are a few things where we actually delegate the authority to you, but in most of the things outlined in the statute you do because you are the local public health authority. So next, myth or fact, local public health officers have legal authority to enforce public health laws. Myth or fact? I can't see the chat.
Fact.
And Bob says fact in the chat.
Well, for Bob, that is true, but generally it is a myth. So local public health administrators are the ones that actually hold the LPHA's enforcement authority, generally speaking. It's with the public health authority, it's with the administrator. And again, it's generally speaking, there are a few things that local public health officers do, but that's really outside of this particular sort of the main statutes. A local public health officer only has the enforcement authority if they are also the local public health administrator. So Bob is both. And therefore, for Bob, that statement is a fact, but it's actually because Bob is the local public health administrator, not because he's the local public health officer, that he has the actual enforcement authority. Now, what's important to note that is in particular as it relates to like actions that might need to be taken related to communicable disease control, those kinds of things. I would expect that a local public health administrator that is not also the local public health officer, probably Bob has a lot of conversations with himself, but most of you are likely having conversations as local public health administrators with your local public health officer and consulting with them to get their expertise and best recommendation around sort of what the situation is. But it's you as the local public health administrator who has the enforcing authority. So this enforcement authority is the reason that a local public health authority must have at least a part-time local public health administrator employed directly by the LPHA. So enforcement is a government function. It has to be performed by a government employee or official. So many health officers are contractual. There's a contractual arrangement with them. So because of that, they would not have enforcement authority in and of itself too, because enforcement has to be done. It's a government function. It needs to be done by a government employee or a government official. So this is one, the governing body, myth or fact, the governing body of the LPHA is the LPHA. Because I've heard some of your commissioners say that. Marie says myth.
False.
Yeah, that's right. So the local public health authority is one of these three things: a county government or a health district formed under a very specific statute, or an intergovernmental entity formed to provide public health basically under ORS 190. So the local, this is what the governing body is responsible for. So with the local public health administrator, so there's an expectation that the governing body and the local public health administrator are working together to develop public health policies and goals for the LPHA. They are responsible for adopting ordinances and rules that might be needed to help support the LPHA in administering the various statutes or any other public health law in the state. They are the ones who adopt civil penalties as it relates to those ordinances and rules. They review and make recommendations on the local public health modernization plan. So the Closed Systems and Innovation Subcommittee is working hard around what those plan templates are going to look like. And the expectation in the statute is that you're going to be working with your governing body around reviewing and making recommendations on what you submit. Also, they have a role in monitoring progress and meeting statewide and local public health goals, including around foundational capabilities and programs, and also adopting fees for public health services. The local public health advisory boards, they do not take the place of a governing body. So a local public health advisory board, which some of you have, is an advisory board, but they do not take the place of the governing body. There's actually, so that's, I think, an important thing to note. And we'll come back to that in a minute, I think. So next one. Myth versus fact. Only a governmental entity can be a local public health authority. Myth or fact?
Fact.
That's correct. For the same reasons that I've already shared, that the statute's very clear about that, and that it needs to be a governmental entity. So again, here's that. But also governance functions cannot be subcontracted or delegated beyond the LPHA. So there are a number of local public health authorities or county governments, and in each case where they have contracted out most of the public health services, but they are not permitted to take out, to subcontract out to another entity the governance functions. And that's why in the Oregon Administrative Rules, we actually have those governance functions spelled out. A lot of those are things that, really require the kind of due diligence and due processes that are available through government that wouldn't be available through a nonprofit. Or it's dealing with things that really are about people's lives and rights in a way that there's an expectation that government would protect those. So let me just say one more thing before questions. I want to go back to the piece around governing bodies. I periodically get questions about Board of Health. When does our Board of Health meet? In Oregon statute, there actually is no Board of Health. The governing body is the local public health authority, kind of is the Board of Health, but Board of Health is not a legal term in the Oregon statutes as it relates to how local public health is set up. And so I think that's something just to be aware of, that when your commissioners don't have to meet as the Board of Health, but because they are the governing body of the LPHA, they have that authority as the governing body. So with that, I'll just stop and see what questions people have. If you have other myths or facts you want to ask about, get this because my phone is chiming. Any curiosities or things you want to ask about?
Well, I'll defer to the group, but if folks don't have questions, it would be great if we could maybe go back to Marie's modernization slides and look at those just for a little bit longer, because I think they're really great, and she's took a lot of time to parse those out where all those functions are in statute. But first, let's see if folks have questions.
So, and Marie, I see your comment. I didn't realize a health district was a government. It is. So, for example, we have North Central Public Health District that is a, they were actually formed under a 190 agreement. So they're an intergovernmental entity. So they're a governmental entity created through the ORS 190 statute is basically a statute that says that different governing entities or government entities can come together through an agreement and form sort of a new entity, and that's what that is. So Wasco, Sherman, and Gillum counties came together and formed the North Central Public Health District some years ago, and now, just as of July 1 of 2022, Gillum pulled out of that intergovernmental agreement and is no longer part of the public health district. And it's now Wasco and Sherman counties that make up that district. And Gillum has its own local public health authority now. Oh, Sarah, you're on mute.
As luck would have it, Marie fell off sometime either right as you were beginning that or as in the middle of it. So she probably missed the vast majority of that.
Well, and now I don't see her in the list.
She just rejoined. Yeah.
Okay.
What was there a question?
I was following up on your comment about a health district. Did you hear my explanation?
I heard something about Gillum.
Right. So we have one health district, and Wasco, Sherman, Gillum years ago formed North Central Public Health District. They entered into an intergovernmental agreement to form that new entity for the purposes of public health, being the public health authority for those three counties. July 1 of 2022. No. Yeah, July 1 of 2020, this year. Seems like so long ago. Gillum County exited that intergovernmental agreement, and now they are their own local public health authority, although they contract out everything but the governance functions to the South Gillum Health District.
Thank you. Yeah, I dropped off right when Sarah was talking about going back to the slides. Thank you both. I don't need accolades. I just build tools to help myself understand, and I'm going to review this presentation definitely and share it with my team because I love learning and I've got several wrong.
Okay.
And
Your
I'm just
understanding's just evolving, Marie.
yeah.
All right, you want to pull those slides up?
Before we do that, just 1 second, I'm gonna share my screen briefly, just to for folks who don't know. So if you are looking for Oregon administrative rules, you can go to the Oregon Secretary of State website and find them here. There's an OAR link. You can also find, in theory, you can find the statutes that way too. However, I usually just go to the Oregon State Legislature website because that's my natural go-to. And then you can search Oregon Revised Statutes here. And it helps if you put in the chapter and then 431, and then you can search for it and it'll come up. So in case you have misplaced your link that Danna has shared in the slides, which we will send out and post on the website later so that you have those easily referenceable, but then you can see here. And then you still, even though you put it in chapter 431, you still have to click through a bunch of chapters, which is really
That's
annoying.
why I just go to the link and then and then it like will slowly populate the volumes. Then I just go to the public health volume. But yes, that is.
So I'm going to stop sharing, Danna, and then you can go
All right.
back to the
Let me do this to make it big. Hold on. Now I gotta swap the thing on. I'm gonna get all my computer pieces fixed here. All right. So, so as I mentioned, the foundational capabilities are only described at a very high level in the revised statutes, but in the Oregon administrative rules, we actually have adopted the Public Health Modernization Manual by reference. And so what you see here, the bottom line of boxes is the vision for each of these different foundational capabilities that's found in the Public Health Modernization Manual. So that's what that is. For those of you who weren't around In 2015, 2016, we did a lot of collaborative work between OHA and local public health to develop the manual. And so what you see when you go to that manual is the result of that work, and it sort of outlines the various functions and roles and whether it's more specific to the state versus local. You know, it is a more dated document. I think those of us local and state folks who were around when we did it, you know, I think we did a really good job for the time that we had it. That work had not really been done before. And so we were kind of on the forefront of it. That, you know, to update it, there was a little bit of updating done, but to update it it's going to be quite a heavy lift. It is something we periodically talk about. And then I think start to twitch and like, wow, do we really want to go back? But to do that. So anyway, that's what that, you know, what the manual is. And then the public health modernization assessment that OHA and all local public health authorities did in 2016 was derived from the manual. So it was assessing capacity and expertise on those various things that are in there. And then for programs, very similar. Again, these things at the bottom are the vision from the public health modernization manual, and then the citation of the statute that citation from the statute that would you know, kind of just gives a very, very high level. And I will say the reason we adopted the public health modernization manual by reference in rule was so that over time, as the manual gets updated, we didn't want to have to necessarily go in and go do a whole new rule promulgation process if we didn't have to, because to put all of that in rule, I mean, that if you've seen the manual, you know, it is quite large. And I think it's the kind of thing that would be pretty difficult to sort of translate into the structure of Oregon administrative rules. And we'll share out the slides. So happy to share out the slides. And I'm always happy to give this, you know, some version of this presentation, because the statutes are like, unless you have spent a lot of time with them, and I've spent a lot of time with our lawyer on them, that you know, there are a lot of nuances. That's why I said some things were like fact mostly.
May I jump in?
Yeah.
Great, thank you. So these slides, I have are companions to additional slides that I've been building to understand how our division is organized. You know, what do we call our programs? How do they align with the, the different foundational programs and our capabilities? And I'm finding that that's helpful to myself and my team and my leadership. I'm further aligning them, I mean, down to the budget level with our reporting categories and our program elements. And so it's an ongoing process of an informal organizational assessment, but it is really helping us to understand how can we modify our structure and to better support a modernized public health system in our county.
That's great work, and a lot of work. I know that Clackamas has done some of that as well a few years ago, and I think others are as well.
Well, any other questions for Danna about statute or rule or the public health manual? Or any other comments that you want to share with folks about any of those things?
I actually had go ahead.
So I have a question about how counties that are where the state is the public health authority, how they are working in modernization. So, my sense is that if you're a county that has relinquished your public health authority, you don't get modernization funding. But does that mean that that county then doesn't modernize?
So in some ways, Bob, yeah, that is what it means. So the way the statute is written, when there's a transfer, the statute enables OHA to use the monies that would have gone to the county for public health modernization to help cover costs related to providing basic public health services. So because we don't otherwise have any revenue that we can use. So in the case of Curry and Wallowa County, the primary funds that are used to help support work in those counties for things like communicable disease control. I mean, there's not really prevention, but like we investigate reportable diseases, or we have a contractor who assists us with that. We have to provide the WIC program. We do the drinking water work. We have to do the restaurant licensure, all of those kinds of things. And then we do continue to do the school law work. It's the modernization money and the state support for public health money that is the primary source of how we pay for that. Because we have to provide those basic services by law based on kind of what some analysis DOJ has done. So just to be able to do that means that we don't have funding to be able to like modernize. I mean, in some ways, when a local public health authority is transferred to the state, they're choosing to not modernize.
I get that, but how does that square then with our goal that everyone in the state gets a modernized healthcare system, a modernized public health system, right? Because that is actually one of the stated goals.
I think that's a good question. I think we don't have a good answer to that currently, because we don't really have a way to do it.
Okay.
So the advice we've received from the Department of Justice is, because we've asked them like, what do we absolutely have to do? Because we don't have access to any local resources or that kind of thing. And it's the small subset. And so that's what we're able to do.
So there had been some regional programs with Curry, like regional epidemiology programs and, coverage for epidemiologists when they were on vacation or maternity leave. And so those were the things, and they've sort of fallen by the wayside in Curry County. And that seems disappointing for the people in Curry County because they really.
Well, that's because we have staff that are doing that work.
Okay. All right.
Yeah, that's how, or we are working with a local partner to do that work.
Marie,
Danna, this is,
comment, go ahead.
yeah, thank you. I had a question, Danna. I think I got myself confused yesterday in a meeting. It's my understanding that program elements are often a good source to find statutes that are specific to the program elements or the topic.
Yeah, they should be. Yeah.
Great. And however, I think where I confused myself is if an LPHA is not engaged, it is not receiving a financial award or does not have a contract for a specific program element, are they still accountable to the programmatic responsibilities within a program element?
So you're referencing, so this is something that has been with where it really applies is around TB and STI work. So those are reportable conditions, and under the law, under the public health laws, local public health authorities are required to investigate reportable diseases. So for many years, there wasn't any funding going specific for TB or for STIs. It was kind of just wrapped up into the state support for public health PEO1 dollars. Like that was the money that folks got, and you could use it sort of broadly how you needed to for communicable disease work. But the program elements specific to TB and to STIs have always been in the public health intergovernmental agreement because they really do spell out kind of the specific expectations around that work, even though there wasn't necessarily dedicated funding for it.
So that,
Since then, there have been some shifts, and there are some dollars that either are reimbursable dollars. So there's been some work around, like we reimburse by TB case. And then there's also been some newer STI DIS money.
that's helpful. Thank you. I wasn't sure how far to generalize that information. That helps me kind of put a focus, and I wanted to further clarify that goes back to the Oregon administrative rule about the responsibility of local public health authorities.
Right.
It says in absence of funding, like as the local governmental public health authority any agreements or receive financial support, kind of that OAR. I have that in my slides too.
Yeah, that I think it's only those two that there's sort of that anomaly with, but yeah.
Thank you.
And I actually, that predates me, so I don't know sort of the history of sort of how that got to that, but. So, other questions? Surprises, things you don't like in the statutes? I don't know, Sarah, if you had other stuff related to the foundational programs or capabilities you wanted to be sure we touched on.
Nope, I think what we did was sufficient for now. And I do know Laura is planning another webinar on public health statutes at a later date that will probably go into much more detail as part of the CLHO leadership development and mentorship program. So if folks are interested in that, please reach out to her and she'll give you more details.
That sounds great. I do want to add that with Family Connects, and I think with some of our programs, they're outside of the public health modernization framework. There are other statutes. And so I am just making a note for myself verbally and sharing with others that this is not a comprehensive view of all statutes and administrative rules that are associated with public health and or our programs.
Right, so that's why there is that, I mentioned there is that part in statute about other public health programs. So because it doesn't capture foundational capabilities and programs, doesn't capture the universe. The idea with public health modernization is that the foundational programs and capabilities would be the basics in a sense, or it would be kind of the core. And then communities would determine if there were additional programs that were on top of that. Or in addition to, I should say.
Thank you. I like that. I saw that or other public health programs. And so I will add that to my list.
I think that was captured well in kind of the early public health modernization graphic. If any of you have seen that, where it's got a box with all the capabilities in the bottom, and then there are these like bars on top. And I think that's, you know, there have been other iterations of graphics since then, and I think that piece has sort of gotten lost in that. And so I think that's one good thing. It wasn't a very pretty graphic, but that was one good thing about it, is I think it provided that piece, that nuance.
That really helps, Danna, because I also heard in a meeting recently base versus enhanced, and I didn't know. I'm like trying to differentiate base versus enhanced, and there's so much terminology. core services, enhanced services.
Mhm. Yeah. And then just in the chat, just reiterating that the recording will be posted, and I'm always happy to do this presentation for folks or do some version of it even for commissioners, because I don't think they have a good understanding of all of this either. So I mean, I think you guys do, but they, you know, they don't spend their time in these statutes, understandably so.
Okay, if there are no additional questions or comments, we can let you go a few minutes early and have some transition time before your next meeting. And just to reiterate, on the CLHO website under the advocacy tab is where we're posting all of our legislative lunch and learn videos, and this one will be there as well later today. Thank you, everyone, and thank you, Danna Drum. We appreciate you.
Bye-bye.
Bye.